26th November 2024. Once again a very important day for me because I'm sitting with one of my very good friend, Dr. Bernard Prendergast, who is not only eminent cardiologist but also one of the important person and director of one of the most eminent valve meeting, London Valves. So I'm here in London today on 26th November in London Valve area, which is being organized, is going on in London Excel, which is a convention center, one of the very east of London. And I think we have enjoyed a lot of things, and I would like to hear from him regarding what actually motivated him to continue London Valve meeting and what was the few messages coming out of this meeting. You tell about how much is the scientific program for 3 days. And once again I invite Dr. Bernard Prendergast for talking to me, and I'm thankful to him.
It's a great pleasure to talk with you, Vivek. So this actually is our 15th year of the London Valve meeting. The first one was in 2009, and here we are in 2024, and there's been huge progress in the field. We have a 3-day meeting that we're very proud of, and this year we have 4,000 people here from all around the world.
4,000?
A new record, and maybe a 20% increase compared with a year ago. So we have had some challenges with disruptions from Storm Bert, and many of our international faculty were delayed in the skies above London, but eventually everyone landed, and we've had a really busy schedule. We've had multiple live cases addressing aortic, mitral and tricuspid valve disease. We've seen new device designs, we've seen complicated anatomy, and we've even seen some challenging anatomical situations which have been very expertly rescued by our live case teams from London, from Toulouse in France, and also from Cologne in Germany. We've also had parallel recorded cases from wider fields, cases from Montreal in Canada, from Tokyo in Japan, and closer to home Vigo in Spain. So it's been a very rich educational program in the main arena. We've also had some great late-breaking trials looking at new devices in TAVI. We've had progress with tricuspid transcatheter valve replacement, and we've also heard the latest outcomes of some of the edge-to-edge mitral repair trials. But perhaps most importantly of all, we've had an enthusiastic attendance from colleagues from every of the 5 continents who've brought their cases, their experience, and we've had a very rich, lively interaction in all of the rooms with a sharing of everyone's knowledge and experience, which of course advances the skill base of everybody. So a true success, and a great pleasure to welcome international visitors such as yourself.
Thanks, Bernard, to summarize this event. Talking a little more about 3 valves, as you mentioned, the transcatheter aortic valve, and then now you have a mitral valve replacement, also percutaneous, and of course the tricuspid evoke valve, which I learned a lot in this tricuspid regurgitation. So we all know that now TAVI, transcatheter aortic valve implantation, is established. So which is now, of course, we have few challenges like aortic regurgitation and small annulus, but that will be overcome, and we have some new devices coming up. Coming on to the percutaneous mitral valve. So how do you think that other than prosthetic mitral valve, where it is being used regularly because you need an anchoring, how do you feel that percutaneous mitral valve technology will also come other than TER? I'm talking of mitral prosthetic valve in a severe secondary mitral regurgitation. Will it come, or there is some?
It's coming. I mean, it's been a longer development curve compared with TAVI, because the mitral valve is a much more complex structure, and particularly the interaction with the left ventricular myocardium is complicated, and also the devices are quite large, so it's an engineering challenge to deliver them into the heart and to get them to anchor, as you say. But next year will be an important year because we have 2 new devices that will be commercially available and will be undergoing their extensive registry studies. The M3 valve, which is coming from Edwards, and we also have the High Life valve coming from the High Life company.
Ring in the valve.
The ring in the valve. And these concepts of implanting a dock or a ring or a platform to secure the valve device itself, it seems to be the most promising way forward at the moment. There are other devices under development. Some of them have had a long journey, but there's a feeling that we're beginning to turn a corner in the field of transcatheter mitral replacement.
Coming on to the small part of TAVI, and that is transcatheter aortic valve implantation, especially in a young age. So what do you think that if a person of age of something like 40 with a severe bicuspid aortic valve stenosis, he wants to choose an aortic TAVI transcatheter, what do you think? What is your recommendation? As of now, the recommendations are not there, but why it should not be done in young people?
Yeah.
And if it yes, I personally feel there is no harm in doing. What is your take on this?
Well, I think we have to be cautious still. We have good survival data in the valves, that is, surviving for 8 or 10 years in a patient. We have good data to support that. But in clinical practice, not all patients reach that time threshold. Some patients, their valve, for whatever reason, anatomical or physiological reasons, the valve only lasts for 4 or 5 years. And if you have your example patient, age 40, needs their second procedure at the age of 44, 45, that's maybe not necessarily the best outcome for them. So we need very convincing durability data. And we also need to remember that a lot of these younger patients have bicuspid valves, and the data surrounding TAVI and bicuspid valves is still to be established. We know that we can do these procedures, and in elderly patients it's the right thing to do. But for younger patients, especially with bicuspid valves, the jury is still out.
Well, surgical valve replacement will still the first choice in young patient.
Yeah, but using modern surgery, importantly. So minimal access, no sternotomy, short time on cardiopulmonary bypass, a quick recovery. Not all cardiac surgery is the same, and you need to make sure that your aortic valve surgeon is an expert in minimal access techniques.
I personally feel that with so much of technological advancement coming up year by year, even if it is degenerates or it is at the age of 45, and you have a TAV, and somebody who is very cautious and he doesn't want surgery at all, can those patients who are actually seriously not looking forward for the surgical valve replacement, is there any harm in giving them? Because then we can do TAV if it all degenerates.
Well, potentially, and you can also, you could take an argument that you could do a TAVI first, and then when the TAVI wears out at the age of 60, let's say, then you could have your surgery, and then you have your TAV and SAV procedure when you're 80. That's an alternative. There are lots of different ways of
treating. Every patient is different. Patient is different.
Many ways to skin the cat, as we say in English.
Do you think with so much of technological advancement in TAVI, do you think surgical, especially for the few indications where still surgery will be there, but I do think after 5 years or 7 years or 8 years, surgery will be almost gone, or we still have say in surgery?
I think for the mitral valve, surgery will still be around, but my prediction is that 90% of aortic valve procedures will be done transcatheter within the next 5 years, for sure.
Thank you very much, Bernard, for giving time to me and for talking about this technology. And we all want that more and more patients should survive this big illness, and which is life-threatening illness. And therefore, we know. I once again give my final tribute to Professor Ellen Crebier, with whom I worked. And I was talking to Ellen Lushaninov. She said that the first case, which was done through transeptal, was supposed to be done in retrograde at that time, but since there were no arteries available at that's why they went to transeptal, and then further they went. Many such patients were done by transeptal technique also. It was not actually planned for the transeptal, but of course, retrograde was planned. So I give my personal tribute. I know you have also worked with Alain Crebier, and we all miss him. Thank you very much. London Valves is an exceptional meeting, and I thank you for inviting me for this special meeting where not only you learn, but we teach, educate, and learn and treat. So teach, educate, learn, and treat. So these are 4 mantras for having a successful conference, and I thank you. And I thank your best wishes for the coming new year, and your family should stay healthy and happy. Happiness is more important. Health, of course, health is wealth, and the peace of mind is second most important, which is required for all of us.
Quite right too.
Thank you so much.
Thank you, Vivek.
Thank you. Bye-bye.